Rhinitis is not a trivial, harmless, or unmanageable condition. Primary care clinicians can support people with rhinitis by helping them understand that attention to triggers, symptoms, and effective treatment can significantly reduce discomfort and improve quality of life. Allergic rhinitis is strongly associated with an increased risk of developing asthma. Around 20 to 30% of people with allergic rhinitis also have asthma. So anyone with confirmed allergic rhinitis should be screened for asthma. They are also more likely to have frequent exacerbations and poorer control than those with asthma alone. Rhinitis is broadly classified as allergic, an immune-mediated response triggered by allergens such as pollen or dust mites. Non-allergic, not triggered by allergens, for example, vasomotor, medication-induced or infectious, and mixed, where non-allergic and allergic features combine. In most cases, people with allergic rhinitis self-manage without seeing a clinician and stop treatment once they feel better, particularly in mild intermittent disease. But it is important to identify those with uncontrolled rhinitis who need further care. When an adult reports 2 or more nasal symptoms of allergic rhinitis and self-care is not enough, management follows a treatment ladder guided by symptom control on a visual analog scale. The visual analog scale is a simple but validated way to assess control. Ask, how much are your nose and eye symptoms bothering you today? From 0, not at all, to 10, extremely. A score of 5 or more suggests uncontrolled disease. Allergic rhinitis is also classified as intermittent when it occurs on fewer than 4 days per week or for fewer than 4 consecutive weeks, and persistent when it exceeds both thresholds. Pharmacotherapy is adapted to the severity and frequency of symptoms. As-needed therapy may be enough for mild intermittent symptoms, including predictable exposures, such as pets. Daily therapy works best for intermittent bouts, which typically last about 2 weeks. Start with initial treatment, including non-pharmacological advice. Reassess after 14 to 21 days and discuss with the person or their caregiver whether the plan needs adjusting. Step 1 begins with an intranasal corticosteroid or an antihistamine, oral or intranasal. Intranasal corticosteroids are preferred, but consider patient preference. After 2 to 3 weeks, if the visual analog scale is below 5, the rhinitis is controlled, and you may step down, especially if intermittent. If it stays at 5 or above, it is uncontrolled. Move to Step 2. In Step 2, escalate to a fixed combination of intranasal corticosteroid plus intranasal antihistamine. Before stepping up, confirm the diagnosis, check adherence and nasal inhalation technique, and review other factors, tobacco, alcohol, or chili in the diet, which may cause non-allergic symptoms that respond mainly to removing the trigger. If, despite correct use and good adherence, the score remains 5 or above, symptoms are still uncontrolled, progress to Step 3. Step 3 is reserved for severe disease. Review adherence, inhalation technique, and the diagnosis again, and consider referral to an allergy specialist. Options include add-on therapies, rarely a short cautious course of oral corticosteroids, and allergen immunotherapy for suitable patients. Consider allergen immunotherapy, including sublingual immunotherapy, for people with moderate to severe allergic rhinitis that stays uncontrolled despite optimal treatment. Strong indications include symptoms that impair daily functioning, sleep, or school and work, or that persist even at low allergen exposure. A confirmed immune-mediated diagnosis is essential, from the history, plus positive skin prick, or specific antibody testing. Bear in mind local allergic rhinitis, nasal allergy symptoms, despite negative specific antibody and skin prick tests. Treat it primarily with nasal sprays, though oral antihistamines and immunotherapy also help. For non-allergic rhinitis, a key step is avoiding identified triggers: tobacco smoke. Certain medicines such as NSAIDs or dietary components. Non-allergic rhinitis, especially from a viral infection, can be treated briefly, for no more than 5 days, with a decongestant nasal spray. But these are not for regular use in allergic rhinitis. Longer use can cause rhinitis medicamentosa. Don't forget non-pharmacological treatment. Saline irrigation thins and removes mucus, clears inflammatory proteins, and flushes out irritants, useful in all types of rhinitis, and essential in chronic rhinosinusitis. Environmental measures reduce exposure. Car filters, sunglasses, air purifiers, masks, pollen screens, and checking pollen forecasts. Finally, monitor and follow up by response. A full response needs no review. A partial response prompts a review of adherence, technique, and non-allergic factors, such as smoking or occupation. Non-response, despite good adherence and technique, calls for diagnostic review or referral. Learning with IPCRG, one breath closer to the right care.